name is Cassie, and I will be presenting my MNT disease project on an RA case study. Beginning with the nutrition assessment, JG is a 48-year-old female. She is also a mother to 3 boys and works full-time as a hairdresser. JG was referred to a registered dietitian as an outpatient visit to provide nutrition education pertaining to her recent diagnosis of rheumatoid arthritis. JG specifically stated that she is interested in changing her dietary habits and meal planning to improve her RA symptoms. No past medical history or surgical history was available on this patient. So now we'll discuss the medications. When JG's symptoms began 7 months ago, she was taking 800 milligrams of ibuprofen a day to minimize her pain. When this stopped working, she went to a primary care physician who ran some tests and then referred her to a rheumatology nurse practitioner. At this time, JG was prescribed low-dose prednisone and corticosteroid injections. When she was officially diagnosed 2 weeks later, she was prescribed oral methotrexate, folic acid, and low-dose prednisone. And that is her current medication regimen. Methotrexate is the first-line DMARD agent used to treat RA. DMARDs are one of the 3 major drug classifications used in the treatment of RA. Methotrexate is a folate antagonist that specifically interferes with the reduction of folic acid to tetrahydrofolic acid by inhibiting the dihydrofolate reductase enzyme. This drastically reduces the cellular pool of tetrahydrofolic acid, which subsequently reduces nucleic acid synthesis. Folic acid supplementation of up to 1 milligram per day can minimize methotrexate side effects without diminishing its efficacy. This is why JG has been prescribed 1 milligram of folic acid daily. Prednisone is a corticosteroid, and corticosteroids work to reduce inflammation and regulate immune activity. It is important to note that long-term corticosteroid use can accelerate the development of osteoporosis. This will be addressed in later slides. So JG does not have a history of being overweight or underweight. She did lose 10 pounds over 4 months. However, this does not meet the criteria for protein energy malnutrition. As discussed on the previous slide, JG is a hairdresser and a mom to 3 active boys, so she is on her feet most of the day. She does not report any additional physical activity though. Regarding her RA symptoms, she does still experience persistent hand pain that interferes with daily tasks, especially food preparation. A 24-hour recall was not available, but JG did report her usual intake. She typically skips breakfast aside from 2 cups of black caffeinated coffee. For lunch, she usually gets fast food. This is typically a hamburger and fries or a Subway sandwich, but sometimes Smoothie King. For dinner, she prepares frozen meals for her and her sons. This consists mostly of chicken nuggets, pizza, and spaghetti. JG does the grocery shopping and cooking. She does not report alcohol use or smoking. So now moving on to her anthropometric measurements. Her current weight is 145 pounds and her usual weight is 155 pounds, which makes her percent weight change 6.5%. Again, this weight change occurred in 4 months, so she does not meet the criteria for protein energy malnutrition. Her BMI is 24.1, which is considered normal. So for her biochemical data, it was limited. So what we have is her RA factor, CCP antibodies, ESR, and C-reactive protein. These items were obtained at her primary care physician visit. And for her RA factor and CCP antibodies, they were positive, and ESR and C-reactive protein were elevated. These biochemical indices were used later to diagnose with JG with RA. It's not really relevant to nutrition, but these were the only biochemical data that were available. So for her estimated energy needs, I used her current weight. So no increased kcal protein or fluid needs are recommended for RA patients. So I calculated kcal needs using 25 to 27 kcal per kilogram, protein needs using 0.8 to 1.0 grams per kilogram, and fluid needs using 1 milliliter per kcal. JG should be consuming around 1650 to 1775 kcals per day, 52 to 65 grams of protein per day, and 1650 to 1775 milliliters per day. So for the nutrition diagnoses, I chose 3 PES statements. So keeping in mind that prolonged corticosteroid use can result in osteoporosis, the first PES statement I chose is inadequate vitamin D intake related to increased needs, as evidenced by limited nutritional variety reported in diet history. Since JG does have persistent pain in her hands and a rapid 3 score of 4, the second PES statement I chose is impaired ability to prepare foods/meals related to physical inability, as evidenced by frequent consumption of fast food and preparation of frozen meals. And lastly, referring to JG's usual intake, the third PES statement I chose is intake of types of fats inconsistent with needs related to food and nutrition-related knowledge deficit, as evidenced by frequent consumption of hamburgers, French fries, and Subway sandwiches. And so the Mediterranean diet is highly encouraged for RA patients, just due to its anti-inflammatory properties. Also, a vegetarian diet can also be recommended. However, the Academy doesn't have any definitive guidelines for RA patients. So a Mediterranean and a vegetarian diet are just simply recommendations that RA patients can choose to follow to see if it will help reduce their inflammation, thus reducing their pain. So that's really the idea behind the third PES statement. So for intervention, 3 SMART goals were developed. So it is recommended that RA patients taking prednisone also take a vitamin D supplement. This is just to guard against the risk of developing osteoporosis. So goal number 1 is to supplement with 600 IU of vitamin D daily. JG can also benefit from incorporating food sources of vitamin D, such as low-fat dairy milk or vitamin D fortified orange juice. If you have a patient that does not like dairy milk, or for whatever reason, JG doesn't really like dairy milk, vitamin D fortified soy milk is an acceptable alternative. And then this goal can be measured by the biochemical indices listed on the slide. It is unlikely that JG will be able to prepare all her meals by herself due to her persistent hand pain, so eating out may be her only option at times. So goal number 2 focuses on making healthier choices when eating out, such as choosing a grilled chicken sandwich on a lettuce bun instead of a hamburger. Goal number 3 is aimed at incorporating fish high in omega-3 fatty acids. Again, this follows the Mediterranean diet. Because omega-3 fatty acids do have anti-inflammatory properties. That's why we want to incorporate fish. So canned light tuna is not only a great source of omega-3 fatty acids, but also a great source of vitamin D. So it has about 269 IU of vitamin D in every 3 ounces. And then additionally, canned tuna requires minimal preparation. So for goal number 3, it really ties in all 3 PES statements. So canned light tuna 2 to 3 days a week in place of fast food for lunch. You can also incorporated in this goal is prepared steamed edamame. Again, that's really high in omega-3 fatty acids, and that can be used as a snack. Canned kidney beans with brown rice. Again, all of these are really easy meal preparations. So canned tuna, all you have to do is open the can, prepare for the steamed edamame. All you do is stick the bag in the microwave and you have freshly steamed edamame. Again, canned kidney beans, open. You can eat it straight from the can, or you can prepare it on the stove top really quickly in a pot. Brown rice can easily be cooked in the rice cooker. So goal number 3 is really good at incorporating all 3 of the PES statements. And so for goal number 2 and 3, they can be measured by doing a 24-hour recall and obtaining a new RAPID-3 score. So for follow-up, this visit did occur in the outpatient setting, and then JG is also considered at low nutritional risk. So follow-up in 1 to 3 months would be most appropriate. And here is a list of my references, and thank you all so much for listening to my presentation.